The enemies we fight against do not slow down. Cancer is relentless. Diabetes is relentless. Time is relentless. So we are relentless. We lose sleep at night dreaming of solutions for wearable technologies, remote monitoring, advancements, innovations, any weapon to win the fight. We are the men and women of Ochsner, and we are relentless. We're doctors and nurses and dreamers and healers, but above all, fighters. Yes, fighters.
Keep working it.
Because when it comes to your health, good is never good enough. So we do not slow down. Ochsner, innovating healthcare.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about cataracts and cataract surgery. Our guest is ophthalmologist Ginny Kullman. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. There's the number. And by email, you can send us your questions to hhquestions@wlae.com. Well, Dr. Ginny Kullman was born and raised in New Orleans. She went to Newman for a while. She received her bachelor's degree at Chapel Hill at the University of North Carolina. Her medical degree is from Tulane. She completed her internship at Deaconess Hospital in Spokane, Washington, and her residency in ophthalmology at the Rocky Mountain Lions Eye Institute at the University of Colorado. That's in Denver. She did her fellowship work in cornea and external diseases at the renowned Massachusetts Eye and Ear Infirmary. She says she's not a member of the Patriot Nation. She's a Saints fan. She's a member of the American Academy of Ophthalmology and the American Society of Cataract and Refractive Surgeons. And it is our pleasure to welcome Dr. Ginny Kullman to Hello Health. Good to have you with us on the program, Doctor.
Thank you for having me.
Yeah, thanks for being here. Because it's your first time with us, what was it or who was it that first got you interested in medicine?
You know, I always thought that I would end up being a doctor. I can't remember specifically an influencing factor without having one in my immediate family being physicians. But that was always the path that I was on.
And how did you end up working with the eye?
Interestingly, I didn't know what ophthalmology was early on in med school, as most medical students aren't exposed to it until later on. But I was lucky enough to have a mentor that sort of took me under her wing, and I was able to shadow her and discover what ophthalmology involved, and that was how I discovered it and became interested in it.
I would think it's a particularly rewarding field of medicine in that you're, in almost every case, able to help people in some way.
It is, and specifically my subspecialty dealing with cataracts and cornea, you know, the goal is to give people back their vision, which is very rewarding.
Well, tonight we're talking about cataracts and cataract surgery. So let's start off with exactly what is a cataract. It's a clouding of the lens, right?
Exactly. So when you're born, we're all born with a clear M&M-shaped lens that sits right behind the colored part of the eye. And part of the natural aging process is a clouding of that lens. And when that lens becomes cloudy, that's what we call a cataract.
Natural part of aging. So does everyone develop cataracts at some point in their life? Just some develop them quicker than others?
Exactly. Unfortunately, there's no way to avoid the development of cataracts unless you can avoid aging. But I tell patients it's just the natural aging process, maturity of the lens, yes.
Still looking for that fountain of youth and haven't found it yet.
Not yet.
How does someone know when it's time to remove a cataract, or even if they have cataracts, because it is slow developing?
Good question. So most patients have early symptoms that involve a blurring of their vision. A lot of times they're describing glare and halos, especially when driving at night with oncoming headlights and traffic. Some people describe their vision like it's looking through a dirty windshield, feeling like colors are just not as bright as they once were. Some people feel like their vision decreases pretty acutely. However, it's really a slow process.
Okay. And the only time I would go see or have gone to see an ophthalmologist is when I'm having real eye issues. I'm a contact abuser, as I opened up with you and told you about. But normally just checking my eyes once a year, that sort of thing for vision. Is that the kind of thing an optometrist would seek? Or does it have to be an ophthalmologist who would identify
absolutely.
cataracts?
Optometrists are great. We work alongside with an optometry team to help assess the development of cataracts, and patients come in, they get their glasses or contact lens prescription updated, and when they determine that that prescription cannot correct vision to the fullest potential, that's when we start to look for other causes, including cataracts.
And how do we know when it's time to replace it?
So it's sort of there's two factors really that go into when is it time to remove cataracts. I have patients that come in all of the time that say, is it ready? And really it's like I said, a two-way conversation. One, you have to have the presence of a cataract. So that's when your ophthalmologist looks in the eye and says, yes, you do have a cataract. Also, the patient has to have symptoms that are consistent with the cataract. Sometimes people have a pretty advanced cataract but are not bothered by their vision. So there's no reason to force anyone to have surgery if that's the case. Conversely, some people have a relatively early cataract but are very symptomatic. In that case, there is a reason to justify cataract surgery. So we just sort of have to balance out the patient's symptoms with the clinical exam.
So if the lens is like a windshield and your windshield gets dirty, you just get some newspaper, spray it with the Windex, get some newspaper, paper towel, and wipe it clean. With the cataract, it's not that easy. You have to remove it, right?
That is correct. The only way to correct cataracts is to remove them surgically. So surgery involves removing the cloudy lens from the eye and replacing it with an artificial clear lens.
And again, just reminding people, it's because it's behind the colored part of the eye. It's not something on the outside where you can just spray it with whatever.
Exactly. A lot of times people think it's actually just a cleaning process, but it's a little more involved, and we are going inside the eye, like you said, right behind the colored part of the eye to remove the cloudy lens and replace it with an artificial clear lens. Yeah.
And I know we're going to get into more details on the surgery itself, but I've actually seen one of these. My mother had cataract surgery, and it was like 5 minutes. And we're able to watch it on the video and cut around and everything else. I mean, how many of these are you typically doing on a day when you would be removing cataracts and replacing them?
It depends on how many operating rooms I have, but for the most part, I'll do about 10 to 15 on a day.
Is that about? It can take 5 to 10 to 15 minutes.
Yeah, usually I tell
start to finish.
patients takes about 10 minutes. Of course, you're there a little longer. Sort of the pre-op and post-op takes longer than the actual surgery. But for the most part, standard cataract surgery is very straightforward, painless procedure.
Okay, and you can do all the coaching in the world, but when it comes to people's eyes and sticking sharp objects in people's eyes, right? There's a worry factor there.
Absolutely.
So talk about the process of training someone to get ready for this. If someone is really worried about them, how do you help them? What are you using to keep those eyes open?
Good question. So it's very normal to have anxiety about cataract surgery. Some people are very sensitive with their eyes especially. So I always try and reassure patients, say we're not going to do anything unless you're completely relaxed. Patients are awake during surgery, but they do have relaxing medicine that they get through an IV. So it's sort of a twilight type anesthesia. And we put in numbing drops in the eye. I reassure patients that there's no needles because a lot of times people just have a fear of needles themselves. So that helps. Patients are also worried about what if I can't keep my eye open? I say you don't even have to worry about that. We put a little device in the eye to help keep it open. Again, if they're feeling uncomfortable, anxious, pain, then they just say, I'm not comfortable, and there's always more medication that we can give them. Really, what the patient needs to do during the surgery is try and relax, and then you're kind of just looking at a bright light, the light of the microscope, and that helps the surgeon if the eye's not moving around. And then you just have to sit there for 5-10 minutes, listen to music, and then you're done.
And again, from a third party, I don't mind sharing, it's scarier than it looks, than it sounds.
Absolutely.
Right?
And a lot of times people that are apprehensive and delay surgery after their first eye, they say, I can't believe I waited so long. I wish I had done this 5 years ago. When can we do my second eye?
Okay. Which brings up the question, we're jumping ahead just a little bit, but so typically you would do one eye at a time, right? And why is that the case? The conspiracy theorists would say, so you can charge me twice. But
Correct. It's really a safety measure. We want to make sure that everything goes well, that the patient's happy, that the refractive outcome is as targeted. So we give at least a couple weeks between two eyes to really make sure that our surgical planning was precise.
okay. And do most people develop cataracts? It's funny how some diseases work, right? Only on the left side or
Right.
only on the right side, and never both. But what about with cataracts?
Usually they are pretty symmetric, but not always. There's varying reasons why people may have a dense cataract in one eye and not in the other. Trauma is one reason. But for the most part, people are going to have pretty symmetric cataracts.
Okay. If you were here, I don't know how many years ago, certainly decades ago, we would be talking about the lens that everybody uses, right? There was probably one lens and there was no choices. But just like with everything else today, there are lots of choices, including new technology with lenses. So talk about what surgeons were using compared to what they're using now.
Yeah. So there's been a lot of advancements, even over the last 10 years, really. The first lens was implanted in 1950, and those lenses were hard plastic, so you had to make a large incision in order for the lens to fit inside the eye. Since then, the actual material of the lenses has changed to more of a flexible plastic acrylic, so we can now fold the lens and insert them through a smaller incision. So that's
Not as flexible as my soft contacts.
not as flexible,
Okay.
but almost as flexible.
Okay.
So that's been one of the major advancements, just a smaller incision, which equals a faster recovery. The next advancement was changing what focal point you could see at. So the standard lens that we've been implanting for the last 50 years allowed you to see it well at one focal point. So most patients say, I want to see well at a distance and wear reading glasses to see up close. Conversely, you can say, I want to see well up close without glasses and wear glasses for driving. So that's the standard lens. We now have premium lenses that are not covered by insurance, but allow you a little more flexibility into your focal points. There's one lens called a toric lens that corrects for astigmatism. And then there's another lens called a multifocal lens that gives you good distance, intermediate, and near vision. And now within the last actual year, we have a lens that combines the two to allow to correct for the multifocal vision plus the astigmatism correction.
Let's go back to when we were very young and our eyes worked perfectly. And I'm not sure we knew what perfect was. We talked about that. But I knew I didn't have any eye issues
Right.
until probably late high school. But what's changing in the eye because it's beyond just the cloudiness of the lens,
True.
right? And can we, or how close can we come to giving us perfect vision?
So the main changes, in addition to the cloudiness, is more of a rigidity. The lens becomes less flexible. So that is a process called presbyopia, whereas when we're 40-ish and younger, we're able to focus distance and near. As we turn around the ages of 40, we lose that ability. So that's called presbyopia. So that's one of the things that we're trying to emulate when we're implanting these upgraded lenses, the ability to see at many different focal points.
Now, and is it the lens itself or the muscles around the eye? What's happening?
So with the upgraded lenses, there's sort of two different classes. One that the muscles in the eye can actually change the shape of the acrylic lens. And then the other class of lenses has different focal points within the lens. So there's concentric rings. So you think of it as more of a bifocal, but it's concentric.
Okay. And the doctors given us some examples of the different vision we can get with these lenses and brought along some images to share with us, right? So let's take a look at those right now.
Yeah, so I just like to share this with patients to get an idea of what kind of vision to expect after implanting different lenses. On the left, you're seeing what would happen if you implanted a standard lens and you targeted your vision to see well at a distance. So you can see that up close it's blurry, versus on the right, the lens implanted depicts a multifocal lens. So you are able to see both distance and near. So this is important if people are, for instance, I think the next image describes what you would see if you were driving. On the left with a standard lens, you may be able to read the street signs and see the cars in front of you, but your dashboard may be blurry. Versus having a multifocal lens, you're able to see at all those focal points.
Does my baseline coming into the surgery have anything with where I'm going to end up? So somebody who has great eyes, doesn't need glasses or contacts at the age of 55, that's how old I am, walks in and is going to get, but has horrible cataracts, right? Great vision other than cloudy.
Right.
Versus me who walks in with my -9 or -9.5, play the symphony violin. So can you get us both to the same place?
Theoretically, yes, assuming everything else in the eye is healthy. You being a little more nearsighted means that your eye is longer than the average eye, so that can make the calculations a little less precise, but we do have some newer technology to allow us to hone in on that refractive target and get excellent outcomes.
Great news. So how does someone know, is everyone a good candidate for these premium lenses? And how does someone know if they're not?
That's a good question. So it requires a conversation, I believe, with the patient and the physician. A lot of times, perhaps patients will fill out questionnaires, or it's a conversation where you're really determining what the patient's expectations are. In addition to your expectations, we have to look at the health of the whole eye and make sure that you're a good candidate for a multifocal lens. So important questions to ask: have you ever had any other eye surgery? This includes retinal surgery, glaucoma surgery, even corneal surgery, like a history of having had LASIK or PRK. That's important to know, and may say, okay, you're not the best candidate for a multifocal lens because you've had a history of retinal detachment. Another question to ask is, do you have severe dry eye? If so, then that's something that we need to treat aggressively before cataract surgery, because dry eye can affect your vision, especially after these upgraded lenses are implanted. So I don't want to implant an upgraded lens and have patients be unhappy after surgery because their eyes are really dry. Something else that we talked about is monovision, which is when one eye sees well at a distance and one eye sees well up close. And with the two eyes together, you're independent from glasses. So some people have what's called natural monovision, and some people have monovision with correction, where they may be wearing a contact lens in one eye. I always want to know if patients are doing that before surgery, because if that's the case, we can emulate that after cataract surgery. If you've never used monovision before, I would be a little hesitant to recommend that after cataract surgery, because sometimes your brain doesn't adapt to adjusting to monovision.
Now, does everyone have a dominant eye over the other? And that's not to be confused with monovision, is it?
True. And it's not necessarily to be confused with right-handed and left-handedness either. When I'm implanting multifocal lenses, I am always checking to see which is your dominant eye, and that's the eye that we want to get really excellent distance vision. And if we need to tweak the non-dominant eye to a little more intermediate or near vision, we can do that. But yeah, that's something important to determine.
Okay. You brought up a great question when you were going through determining if someone's had surgery before, are we a good candidate for premium lenses? So if someone is knowing that these premium lenses are available at some point, and actually you don't have to wait for cataract surgery, right? If someone so in my case, horrible eyes, and I said I don't want to wait
Right.
for cataract surgery, then insurance probably isn't going to cover any part of it.
True,
right?
but you
It's
can
gonna
definitely
pay
still.
for the whole surgery. That's right. But if, for example, at 40 years old, I said, I'm going to wait on cataract surgery or replacing the full lenses, and I'm just going to get LASIK or some form of that. Are you suggesting that people wait and not? So what are the pluses? And because many of your colleagues do LASIK surgery.
Absolutely.
So
Yes. and
walk us through that.
LASIK is great for various people that can't tolerate contact lenses, for example. It does change the shape of your cornea, and we use those corneal measurements when we're determining which lens to implant. So it can make your calculations a little less precise when we're going to do cataract surgery. So if you're on the cusp and you are, a couple years away from needing cataract surgery, I would maybe hold off on doing any refractive surgery like LASIK, or like you mentioned, if it's within your financial means and you're 40-ish and you want to do vision correction, and you can look into just having your clear lenses removed without having cataracts.
Okay. And you talked about insurance not covering the high definition premium lenses. Is insurance going to cover everything else that goes along? Because there's not just the lens you're paying for,
Absolutely.
right? It's the anesthesia, it's the surgeon and those sorts of things, the operating room in some cases.
Yes. So everything as far as the cataract surgery is concerned is medically indicated with the diagnosis of a visually significant cataract. So all of that is covered. It's solely the upgraded lens that is not covered. And it's reassuring a lot of times to tell patients that lens is for life. You'll never have to exchange it. It won't run out. So you sometimes have to calculate how much you're going to pay for glasses or contacts over the course of a lifetime and compare that to the cost of these upgraded lenses, and sometimes they can really balance out.
Great points. So what kind of questions should a patient be asking to try to decide, first of all, to go forward with the operation or not, and then secondly, what lens to use?
So as far as what lens to use, I like to talk to patients about what their expectations are and what their hobbies are. It's also important to look at their glasses prescription or contact lens prescription before cataract surgery. For instance, someone that's nearsighted, like you, may be used to seeing well up close without glasses. So that's something that you want to talk about and say, after cataract surgery, if we put in these standard lenses and you can see well at a distance, you will no longer be able to see up close without glasses. Is that going to bother you? And a lot of times,
Yes.
yes, exactly.
Yes. Okay.
So that's really important. I've had lots of patients you hear about patients being disappointed about, I could read up close before cataract surgery and now I cannot. So that's something, it's really important to clarify expectations. Talk about some people enjoy wearing glasses and want to wear glasses after cataract surgery. So if that's the case, I wouldn't necessarily recommend spending the extra money on these upgraded lenses. It doesn't mean that you cannot, but it also means that you could just do the standard lens and wear glasses. We talked about, what your hobbies are. Are you active? Do you like to play golf? Those would be maybe reasons to pay for an upgraded lens to give you the ability to see the ball up close and far away. Of course, there's always some, I say in order to be able to get the ability to see distance, intermediate, and near, there are always some trade-offs. Some patients do notice glare and halos at night after having these special lenses implanted. It usually goes away. Your brain adapts to the new lenses, but I always like to warn patients of that. And if some patients say, that would really drive me crazy, even though it wouldn't be debilitating, I don't want to risk having issues with glare and halos, then we may talk about just the standard lens.
Is that something you can simulate? Because I don't know what halos, and I've heard my aunt, for example, talks about tough to see at night or drive at night.
Yes, absolutely.
I don't know what that looks like, so.
Yeah, some people describe it as, more like starbursts around lights. And if you can imagine, rays of light going in all directions. A lot of times people have these symptoms before cataract surgery and it's debilitating. They are no longer driving at night. the glare and halo I find after these upgraded lenses is not debilitating. It's there, and patients are aware of it, but they're not super bothered by it. And it's helpful as well to give them that heads up that they may notice it, and then they're not so bothered by it, and it usually goes away.
Because you've dealt with so many patients over the years, do patients ever ask you, even though it's a very personal thing, doctor, if I was your mother or I was your father, what would you recommend?
Yeah, absolutely. And like I said, you have to look at all sorts of factors with their eye. And let's say, assuming that they have the financial means to afford an upgraded lens and the rest of their eye is healthy, and they don't have any other irregularities of their corneal surface, for instance, then for the most part, I do recommend the upgraded lens.
Okay. And these are important decisions because they're fairly permanent, right? While
True.
it is possible to go back and replace the lens, it's not something that's done on a regular basis, and there would have to be a real strong case for doing that, right?
Exactly. We try to not go back in the eye after the lens is implanted if we can help it.
Okay. And how is it implanted? How does it, what is it adhering to? We see some little, almost looks like a hurricane.
Exactly.
At the Weather Channel. So
Yes.
how is it, exactly how are you attaching it? And are there ever, I have heard that there's sometimes might be some issues
Yes.
with that.
So if you think of the cataract like a chocolate M&M, I describe it like an M&M, you are keeping that candy coating intact while removing all of the chocolate. And when you're implanting the plastic acrylic lens, those hurricane-like wings that you're describing, that's called haptics. So those spread out within that candy coating, and everything kind of seals into place. So there's no sutures involved, no glue. It's just supported within that capsule.
You ever have patients report floaters or anything like that? What are some of the possible side effects that you could have?
Yeah, people who have floaters before surgery may still see them after surgery. I always tell patients that cataract surgery is not going to get rid of the floaters. Same thing with dry eye. A lot of times people say, I have severe dry eye. That's not going to get better after cataract surgery. It's also not going to get worse after cataract surgery. So those are the main things. We want to set realistic expectations and make sure that people coming in saying, I'm having problems driving at night, my vision's just not clear. I want to make sure that that's because of a cataract and not something else. We don't want to remove the cataract and the patient's having the same symptoms because of another disease that's going on.
Tonight we're talking about cataracts and cataract surgery. Our guest is ophthalmologist Ginny Kullman, Dr. Ginny Kullman. So there's traditional cataract surgery. We talked about different lenses, but there's different types of surgery, right?
Exactly.
Traditional cataract surgery and laser cataract surgery. Talk to us about the difference there.
Yeah, so, when I was in my training, people would come in and say, the cataract's removed by a laser, right? And I'd say, oh no, you're thinking of LASIK. This cataract surgery, we do not use lasers. We use ultrasonic energy to break up the cataract and remove it. We can't say that anymore because now, within the last decade, we have lasers to help do some of the steps of the cataract surgery. So again, this is sort of gets lumped into the upgraded premium package. Whereas, like I mentioned, standard cataract surgery just uses ultrasonic energy to break up that chocolate and suck it out, versus laser cataract surgery, you can see on this image here on the right, does some of the steps. It can make the incisions for you so you don't have to use blades, and it can sort of break up the cataract, and it forms these grid-like patterns. So when we do go in to remove the cataract with our ultrasonic energy tools, we're actually using less energy.
So how is that beneficial to you as a surgeon? And more importantly, how is that beneficial to me as a patient?
So it's important in certain situations. Not everyone needs laser cataract surgery. If you just have a standard cataract that's moderately dense and you are just having a standard lens implanted, those people do very well with standard cataract surgery. The benefits of laser cataract surgery is a more precise surgery. So several steps are done by the laser, including the incisions in the capsular rhexis, which is the anterior opening of the capsule. So that is done in a perfect circular fashion. So when we are implanting these special lenses, they can be perfectly centered. The outcome of having had those lenses perfectly centered does improve your vision afterwards. So overall, I would say it's a more precise surgery. It's less risky and less energy used in the laser cataract surgery.
More precise results?
And more precise results, exactly. Sometimes if you have a little bit of astigmatism, we can correct those as well with the laser by doing small incisions in the cornea. And studies have shown that the results are a lot more reproducible and precise when we use a laser than when we use a blade.
All right. Not the primary focus of tonight's discussion, but you've mentioned astigmatism several times tonight. So remind our viewers of what an astigmatism is and how it factors into a cataract surgery in correcting eyesight.
Yes. So astigmatism is when your eye is shaped more like a football versus a basketball. So if the cornea is distorted in that sense, then your vision is going to be distorted as well. A lot of times astigmatism can be corrected with glasses or contacts. And then if we're doing cataract surgery and you do have a fair amount of astigmatism, then we want to correct that as well. And we do that with either an astigmatism correcting lens called a toric lens, or we can do incisions in the cornea with the laser as well.
Okay. As great a surgeon as I'm sure you are and your colleagues are, there are going to be some people who aren't completely satisfied when it's all over. So what types of folks would fall into that category?
Yeah.
And
So
for what reasons?
I often have patients who say, you know, my neighbor had cataract surgery and she's not happy. A lot of times it really comes down to specifying what their complaint is and clarifying what that actual intention of the cataract surgery is. I've seen patients that come in that say, I'm disappointed, I can no longer read. And then you say, well, how is your vision with reading glasses? And they say, oh, it's perfect. So perhaps that surgeon wasn't clear, or the patient didn't understand that when you do cataract surgery with the standard lens, that we're targeting you to see well at a distance if that's what the patient wants, and then you need reading glasses. So that's a common unhappy patient. Sometimes if patients are describing that their vision fluctuates over the course of the day, especially after reading, then that is just a factor of dry eye, and we can treat that dry eye and patients are more satisfied with their vision. It's not that the cataract surgery gave them dry eye. The dry eye was probably present before cataract surgery, but they didn't notice those mild fluctuations in vision with the cataract present and are more sensitive to those changes after cataract surgery. A lot of times people come in and need cataract surgery, but they also have other pathology going on. They could have severe diabetic retinopathy. They've maybe had a retinal detachment, glaucoma. So in those cases, I do heed caution and I say, your vision's going to improve. We just don't know how much, and it's not going to be perfect. So we have to, reinforce that after cataract surgery if patients are disappointed. And I can say, well, remember we talked about the fact that you've had a retinal detachment and you've had some permanent damage to the retina. Therefore, we can't expect this eye to be as good as your fellow eye. So that's something else to clarify. Another thing that we always look for after cataract surgery is something called posterior capsular opacification. And that happens pretty frequently after cataract surgery. It can happen a month to 10, 20 years after cataract surgery, where you develop some scarring behind the lens. People describe it's like the cataract is coming back. It's really not the cataract's coming back, it's just some scar tissue that's developed behind the lens. And when that happens, we can do a simple laser procedure in the office to kind of break a window in that scar tissue to give you back the vision that you had after cataract surgery.
All right. I don't know if the doctor remembers the $6 million man or $6 million woman, but I do, and I'm going to ask her at the end of tonight's program, is that day coming where not only can you get me back to 20/20 and very good vision, but is there such thing as supervision? And I wonder if that day is coming. We'll ask her that at the end of tonight's program. In a moment, we're going to ask Dr. Kullman for some take-home points, a summary of what we've talked about already tonight. But first, I want to invite you to call us with your questions about cataracts and cataract surgery. Here's our phone number, 504-866-3200. That's 3200, or you can email questions to us, and here's our email address, hhquestions@wlae.com. So, Doctor, before we take a break and while people begin to call us with their questions about cataracts, what do you want our viewers to remember about tonight's presentation?
So I'd like to kind of reinforce that there is no perfect lens for every patient.
Now. Right.
Maybe in 20 years there will be the perfect lens. But there's the best lens for you, which may be different from the most appropriate lens for my father, which may be different from someone else. So I think it's important to have a conversation with your physician about the health of your eye and your expectations and what the best lens for your situation would be. Also, be careful if you hear about 100% guarantees after cataract surgery. It's really hard and impossible to tell patients that 100% you're going to have perfect vision in both eyes after surgery. That's of course what we're striving for, but I don't like to guarantee or promise anything. You want to have realistic expectations. And then lastly, just to communicate your goals and desires with your cataract surgeon.
Very good. Well, we're going to take a break and come back with your calls. Again, our phone number is 504-866-3200, 504-866-3200, and we'll have that on the bottom of our screen here in our second segment. And again, there's our email address for your email questions, hhquestions@wlae.com. Our guest is ophthalmologist Ginny Kullman. We'll be back with your questions in a moment. This is Hello Health on WLAE.
I love taking care of my mom. It wasn't easy at first. She learned how to better communicate her needs.
And you learned how to not ignore yours.
I discovered how to make healthier meals.
And I discovered how much I enjoyed them.
Becoming a caregiver is a learning experience for everyone. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving.
And welcome back to Hello Health. I'm Tom Bagwell. Good to have you with us tonight. We're talking about cataracts and cataract surgery. Ophthalmologist Ginny Kullman is our guest. And we've got lots of questions coming tonight. Again, our phone number is 504-866-3200. That's 504-866-3200. Or you can send us questions by email, hhquestions@wlae.com. Let's go to line one. Mitch is calling us from Algiers this evening. Mitch, welcome. You're on Hello Health with Dr. Kullman. Mitch, are you with us? Looks like we may have lost Mitch. Mitch, please call us back, 504-866-3200. Let's go to our next call, line two. John is with us from Metairie. John, I hope you're there. Are you? John, are you there?
Yeah.
Okay, John, go right ahead with your question for Dr. Kullman.
Hello.
Yes, John,
Hello.
Go ahead with your question, please.
Hello. Hello.
John, we're going to ask you if you can lower your television. Stay on the phone, please.
Yes,
Lower your
Can you hear
television
me?
and go right ahead with your question
Yeah,
for
the
Dr.
question
Kullman.
is, I had cataract surgery.
John, are you still there?
Okay.
Go ahead, John.
I had cataract surgery in both eyes, and I had the regular lenses. Can you hear me?
We can hear you fine, John. Go right ahead.
Okay, I had cataract surgery in both eyes. It was in March of this year. One in February, the end of February, and one in March. And I had astigmatism in a right eye. But the doctor, the surgeon checked it out, and he didn't go with the good lens that Medicare didn't pay. He went with the other lens. Because I was on the borderline, he said we didn't need that special lens that Medicare didn't pay. So he went with the regular lens, regular lens. But I still have to wear glasses to read and drive and everything. I thought with the cataract surgery, wouldn't have to wear glasses, and gotta wear glasses, do everything,
Okay.
I was just wondering, what happened,
So sometimes that does happen, John, after cataract surgery. We try and correct all of the correction that we can. It sounds like you may have been in between the cusp of needing an upgraded lens. So that would be my first question to ask your doctor, what is being corrected in your glasses? If it is just a little bit of that residual astigmatism, then there may be other ways to correct for that. Sometimes you can go back and make some small incisions in your cornea to mitigate or get rid of the leftover astigmatism, and that may help refine and correct the vision for distance if that's what the surgeon was targeted for. It probably is that you will need to wear glasses to see up close, but there may be other things to look at to help improve your distance vision to get you independent of glasses.
Thank you so much for your question, John. I appreciate it. Let's go back to line 1 where Mitch was holding for us. Mitch, are you back with us?
Can you hear me?
Yeah, go right ahead, Mitch.
Oh, thank you, Dr. Kullman. Good evening. I'm a patient of ours, and I have ocular hypertension, pressure in the eyes. I'm taking drops for that. And I am noticing, like you said, seeing, I guess you call them flares at night, but the bright light source, it's almost like a stream of light coming back, like when I'm driving, like a stream of light coming from the source back to me. It's only pretty much when I'm looking through a windshield. When I'm outside the car, I don't notice it. And both eyes are the same. I close one eye and close the other. Is this indicated a cataract? I want to ask my doctor the last visit if I had one. They said very small. Would it show up that soon?
Absolutely. It sounds like you said that you have high pressure in the eye, that you're being treated with eye drops, and that you're having some visual symptoms that can be consistent with a cataract. Even if the cataract is what you say is small and you're having some visual symptoms, sometimes there's some additional testing that we can do to say, is this really a cataract that's affecting your vision, especially if it's impacting your driving at night. And that may help us justify doing cataract surgery sooner than later. So my recommendation would be, maybe go back to your eye doctor and say, I'm really having trouble driving at night. Can you check and see if the cataract is causing these problems?
All right, thank you so much. Go ahead, Mitch. I'm sorry, did you have a follow-up question? Okay, doctor just thanking us. Okay, thank you. By the way, we'll have Dr. Kullman's number set up just for viewers of this program at the end of tonight's show. Let's go to line 3. Frank is calling us from Mississippi this evening. Frank, welcome. You're on Hello Health.
Good evening, guys.
Good evening, Frank.
I can barely hear you.
We can hear you just fine. Go right ahead.
Okay. First of all, thank you for taking my call. I'd like to warn everybody, beware before you get any eye surgery. Check out the doctor thoroughly for complaints of any kind. Because I'm going to tell you what's happening today. It's not like the 70s, 80s, or 90s, or I've had surgery in 2003. In those days, the doctors would have you get there at 6:30 in the morning, do their operation at 12 noon, 1 o'clock, they would be back in their office. Not so today. They operate from 6:30 in the morning till 7 at night. Now, I wouldn't want to be that last patient, okay? That's like playing roulette.
Well, thank you for your call, Frank. Let's go ahead and get Dr. Kullman's take on all this. I don't know if I asked you on the air or before, but how many would you do typically in a day? You said anywhere between 10 and 15. That doesn't sound to me like you're in the operating room for 10 to 12 hours.
That is a rare occasion for cataract surgeons, at least where I'm practicing. We do start at 7, and on a good day that's moving fast, we can be done by 2 or 3 in the afternoon. So we're not rushing off to clinic. But we're also not operating at 7 o'clock at night. I agree, that's a long day.
Right. And again, the doctor shared with us earlier questions she would be asking of any surgeon who would be operating on the eyes, and we would certainly encourage that for our viewers and anyone going to have any sort of a medical procedure. Ask good questions on the front end. Let's go to Metairie, where Joe is holding tonight on line 4. Joe, welcome. You're on Hello Health.
Thank you. I learned that during the cataract surgery, the capsules that support the eyelid could collapse. My question to the doctor is, what caused the collapse of the capsule? Could it be due to the surgeon's mishandling, or could it be due to other factors?
That's a good question, Joe. Like I mentioned, the capsule is what helps support the lens, and our goal during cataract surgery is to keep that capsule intact. There are some conditions that are out of the hands of the surgeon that may affect the stability and the strength of that capsule. One condition is called pseudoexfoliation. And in those cases, we go in to do surgery and the capsule is just not strong enough to support a lens. There are other times, if the cataract surgery is complicated, then there may be some, iatrogenic weakening of the capsule. And if that's the case, then we put the lens in front of the capsule instead of inside of the capsule. So that's sort of an alternative location for our intraocular lens implant.
Would you know that, doctor, on the front end or before even going into surgery, or is that the kind of thing you would discover during what would seem like traditional cataract surgery and then have to call an audible?
A lot of times we can see that when we're doing our preoperative exam. That's one of the things we look for. A lot of times, another explanation for weak capsule would be trauma. So there's several steps we measure and we look at when we're doing our cataract evaluation to make sure that that capsule is secure and intact.
Okay. Our phone number is 504-866-3200, 504-866-3200. We do have some lines open. You can also get a hold of us by email. Our email address is hhquestions@wlae.com. In fact, here's an email, doctor. I've always had starburst type of vision at night. However, I do not have cataracts yet. Will that change after I eventually get cataract surgery? And I'm assuming that the person is hoping for the better, although is it possible that it could get even worse?
Right. I would want to look further into what's causing those starburst vision at night. Some people just are very light sensitive if they have light colored eyes, for instance, and they just tend to not see as well in poor lighting. Another cause of visual disturbances at night can be dry eye. If the surface of the cornea is not well lubricated, then that can cause some refraction of the light, causing some starburst. So I would want to make sure that there's various things to look for and possibly even try and treat to minimize those visual disturbances that you're describing.
Okay. Very good. Our phone number again, 504-866-3200, 504-866-3200. See it there on the bottom of our screen. And there's our email address too, hhquestions@wlae.com. And we have some emails coming in right now. Doctor, just because may have been Mitch who brought it up earlier, the whole idea of the sorts of questions that patients should be asked. Should that be one of the questions? How many of these would you be performing in a day? How many would you typically be performing in a day?
Yeah, I think that's a fair question. You have to understand the setting that the surgeon is operating in. Some people are operating in a surgery center with a much faster turnover. Sometimes surgeons have 2 rooms, so that allows them to, be able to do 30 cases in a day, versus some surgeons prefer to, spread them out a little bit and just do 5 cases a day. But I definitely think that's a fair question to ask. A lot of times patients ask me, I want to be the earlier case, or I don't want to come in so early, I want to be towards the end of the day. So hopefully we can work with patients as far as, accommodating your needs.
Okay. And I guess just to, again, address his concern, if you were having, we all have bad days, right? If you were having a bad day or extra tired and you had 2 extra surgeries lined up in the day and you're not at your best, would you, or has there ever been a time you've just said, you know what, patient health is too important here, we'll come back and do this tomorrow, and that's the right call to
Absolutely. I agree 100%. I can't think of a personal situation that's happened in. I think as surgeons, we just sort of have good muscle memory, and we can, sort of block out any other extenuating circumstances. I've never, if you're sick, for instance, maybe you can power through a clinic, but you wouldn't necessarily want to, do surgeries on that day. So that would be another reason to sort of slow down your day. But I think you have to trust your surgeon to know when there's enough.
Yeah, and I'm sure that day's coming for me, and of having cataract surgery. And if you had to, or anyone else, I'm talking to all the ophthalmologists out there, if you ever had to say, I'm not at my best, or this is the last one of the day, we'll come back and do this tomorrow, I know your schedule, that's perfectly fine with me.
Yeah.
I'll reroute the schedule. I'll reroute the schedule too. Let's go to line 1. Stephanie calling us from New Orleans. Stephanie, thank you for holding. You're on with Dr. Ginny Kullman.
Yes, I had cataract surgery in both eyes 1 year ago. Now, all of a sudden, I'm having swelling in the back part of my eye. What would cause that?
Thanks, Stephanie, for the question. Do you have diabetes?
No, I don't.
No, you don't. Okay, well, that's important. A lot of times you can develop swelling in the back part of the eye that is associated with diabetes. If you do not have diabetes, then I would definitely recommend a retinal evaluation to make sure that there's nothing going on that can cause that swelling. Assuming the cataract surgery was not complicated and that you did well in the immediate postoperative period, there may be something else going on, some inflammation in the back part of the eye that's causing swelling, and it may not necessarily be related to the cataract surgery itself.
Stephanie, we hope you'll get that checked out, and thank you for calling. And doctor, can you talk to us about, so someone else is typically driving you home, right? I think with my mom, I drove her and drove her home. And what, are we keeping ice on the eye, or the eye's bandaged for a typical surgery, right?
I usually just put a clear shield over the eye so the patient can actually see through it, but they are protected so they don't accidentally touch it or rub it. We give patients dark sunglasses to wear outside because a lot of times they're light sensitive.
And they're not the hippest looking things.
Not the hippest looking things, no. Not very stylish, but practical.
Yeah.
And I just tell patients to go home and take it easy. You can watch TV, you can eat whatever you want, you can go for a walk. The only real restrictions are no real strenuous exercise, heavy lifting, or swimming for 1 week. But other than that, I tell patients that you're pretty much back to your normal activities and routine the next day.
And is the eyesight, is it that quick, or is it's going to take a month for your brain to adjust to the new lenses or any of that?
A lot of times it's patient dependent. Sometimes if the patient has a really dense cataract that requires a lot of energy, you're going to be seeing better the next day, but it may take a few days for the vision to really become more perfect. A lot of times patients are seeing well the next day, but I always try and manage expectations and say, don't worry if it's a little blurry on the first day, it's going to still improve.
All right, got just a couple of minutes left and 2 callers left, doctor, so we'll try to get through these quickly. Line 2, Camille calling us from Kenner. Camille, welcome. You're on with Dr. Ginny Kullman.
Hi, Dr. Kullman. My name is Camille. I'm calling from Kenner. I'd like to know if you are currently accepting new patients and what's your location if you are.
Thank you, Camille, for calling. I am accepting new patients, and I practice at Ochsner main campus, and I also travel to Covington, and Baptist as well.
Camille, thank you. And we'll have a number set up, again, just for viewers of this program to set up an appointment. But thank you for calling. Line 3, we have 2 more callers, Doctor. Line 3, Patrick, calling us from the North Shore in Mandeville. Patrick, go right ahead.
Hello, Dr. Kullman. How are you?
Good, thank you.
My question is that I had a broken blood vessel behind my retina, and when it's time for cataract surgery, how would that affect? As of right now, it's still a little distorted in my left eye, and when it's time for cataract surgery, how would the lens affect my sight if I still can't see, well enough as of right now?
So that's a good question, Patrick. That goes back to sort of managing expectations and getting a good history of all sorts of ocular conditions that are going on inside of the eye. In light of the hemorrhage that you're having in the retina, that may be a reason to not recommend an upgraded lens. If you're having a little distorted vision now, if you were to have an upgraded lens implant, I think you would not be happy. The vision may be even more distorted. Having said that, you would do very well with a standard lens. You just have to have realistic expectations, knowing that whatever part of the retina is affected from the bleeding, that would not necessarily change after cataract surgery. There may be additional therapies that the retinal surgeon may be doing to help minimize or get rid of some of that bleeding, but it doesn't necessarily mean that you're not a good candidate for cataract surgery. You would do very well. You just may not be a great candidate for an upgraded lens.
Thank you so much, Patrick. And our final question is from Paul in River Ridge. Paul, go right ahead. You're on with Dr. Kullman.
Yeah. After cataract surgery, is it possible for more cataracts to grow in? And I need to get the name of a real good eye drop for dry eyes.
Okay. There is something called, people call it a second cataract. However, it's not really the cataract coming back. Once the cataract is removed, it's gone forever. But you can develop some scarring, some scar tissue that can develop behind the lens. It feels like your cataract has come back, but in fact it's just some haze clouding that's developed behind the lens called a posterior capsular opacification. And when that happens, you can do a laser procedure in the office to break a window in that scar tissue.
And the last question was for recommendation on eye drops for dry
Yes, so
eye.
I don't have any favorite artificial tears. I say anything that says moisturizing, lubricating for dry eye, I would definitely steer clear of anything that says get the red out. Those are not necessarily good for dry eye, but there's dozens of brands, Sustain, Refresh, Optive. Those are good go-to ones, but the generic ones work well as well.
All right. Thank you to all our callers for your great questions tonight, email as well, and to Dr. Kullman. Great to have you on the program, and I hope you'll come back to be with us.
Absolutely.
Thank you very much.
Thank you.
All right. Dr. Ginny Kullman. I want to thank her again for the education and information she's provided tonight and for her work in the Ochsner Health System. She's home. To make an appointment with any Ochsner physician, including tonight's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at this number. Here's the number we promised you, 504-842-5669. 842-566-5669. You can watch our programs on demand. As a reminder, there they are at WLAE.com or Ochsner.org. In fact, there's one of your colleagues, right? Dr. Poulin Shaw, who's a frequent visitor on this program. Well, again, we want to thank our guest, doctor tonight, Dr. Kullman, and you for your support of our program, WLAE, and our station, of course, WLAE and Hello Health. Good to have you with us tonight. Thanks.
The enemies we fight against do not slow down. Cancer is relentless. Diabetes is relentless. Time is relentless. So we are relentless. We lose sleep at night dreaming of solutions for wearable technologies, remote monitoring, advancements, innovations, any weapon to win the fight. We are the men and women of Ochsner, and we are relentless. We're doctors and nurses and dreamers and healers but above all, fighters. Yes, fighters.
Keep working it.
Because when it comes to your health, good is never good enough. So we do not slow down. Ochsner, innovating healthcare.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.